physiologists and physiologists. This video is still about the respiratory system. Today we're talking about ventilation. Quickly recap before we get started into this, what we covered last time. So the respiratory tract begins with the nose, continues through the nasal cavity, down the regions of the pharynx, into the larynx, through the trachea, and then the trachea splits off into different tubes, right? And those tubes are called the bronchi. And then that gets us into the lungs, right? And so we have a right lung, we have a left lung. In the right lung, we have 3 lobes. In the left, we have 2, plus that cardiac notch there. And each of the lobes of the lung are divided by those fissures. The lungs are also covered with this serous membrane called the pleura. There's the visceral layer, the parietal layer, and that cavity there in the middle. Okay, so once that trachea splits off into those 2 bronchi, then we're in the lungs. And those bronchi, they branch and they branch and they make a bunch of branches upon branches until you're at the tiniest portion of the lungs, which is the actual site of gas exchange, which is called the alveolus. And that's the grape-like structure we talked about. Okay, so that's what we talked about last time. The other thing that we need to remind ourselves of is the process of respiration. There's 4 major processes of respiration we talked about last time. The first was pulmonary ventilation, the breathing part, and that's the inspiration followed by the expiration thing at the level of the lungs. Then gas exchange occurs still in the lungs, but at the level of the alveolus, and that's called external respiration. And now that that oxygen is in the blood, we need to transport it. So we transport it in the transport step. And then lastly, that oxygen is delivered to the tissues. CO2 is dropped off into the blood. That's called internal respiration. Today, what we're looking at is pulmonary ventilation. So we're looking at pulmonary ventilation today. So let's talk about inspiration and expiration. The first question that we're asking is, if we're talking about the movement of air, we need to understand why air moves in and out of the lungs in the first place. And the major reason behind these pressure differences. So within the lungs, that aids in the flow of air in and out of the lungs. Pressure changes in the lungs, but the pressure around us in the air is pretty much always the same. And that pressure in the air is called atmospheric pressure. And that's the pressure of the air in the atmosphere, or the air around the body. And this atmospheric pressure sits pretty steady at 760 millimeters of mercury, or 1 atmosphere. These numbers are important for us to understand, but the units, just know that those are units of pressure. So know that as this number gets bigger, pressure increases. As that number gets smaller, less pressure. Atmospheric pressure is important to know about because we use atmospheric pressure, or PATM, when we're talking about the changes in pressures in the lungs, because we're using PATM as like a reference point. So we'll look at that and compare between whatever respiratory pressures we're describing. And this can be different changes. There can be negative changes, which means that the pressure in the atmosphere is greater than the pressure in the lungs. So that would be a negative respiratory pressure because the lungs have less pressure. Or it could be a positive respiratory pressure, so that pressure in the atmosphere is less than the pressure in the lungs, which means that that pressure in the lungs is bigger than that of the atmosphere, so it's a positive thing. When the pressure in the atmosphere is the same as the pressure in the lungs, then we call that a zero respiratory pressure, because that difference is just 0. So the pressure in the atmosphere is on the outside. So what about on the inside? In the lungs, we describe the pressure within the alveoli. There's a lot going on in this slide, so I'm going to use red for my marker. So the intrapulmonary pressure, which I'll highlight first, intrapulmonary pressure, or PUL, this is the pressure in the alveoli. Alveoli. The alveoli are the site of gas exchange, and the inspiration and the expiration of air will increase or decrease based on the pressure that's inside the alveolus. But it all comes down to the pressure in the atmosphere. Is the atmosphere pressure more or is the atmosphere pressure less? And that atmospheric pressure stays around the same. Okay, so the next pressure to talk about, before we move on, I need to remind you that intrapulmonary pressure, or the pressure in the alveoli, it changes quite a lot because we're breathing. We're breathing in, we're breathing out. So this is very dynamic. And while it's very dynamic, that pressure in the alveoli is always trying to come back to that pressure in the atmosphere because that's what stops the processes of inspiration and stops the process of expiration. Okay, the next pressure that we're discussing is intrapleural pressure, or PIP. This is the pressure inside of the pleural cavity. So inside of that serous membrane, the pressure in the pleural cavity isn't like open to the outside, right? So this pressure is usually lower than that of the pressure in the alveolus. But it's not really like a site of gas exchange or anything like that. It's just the surrounding bits of the lung. So this pressure is always less than that of the intrapulmonary pressure, so the alveolus one. But it also changes, just like the intrapulmonary pressure does, with the phases of breathing. But the difference is it doesn't change back to the atmospheric pressure. So while the interpulmonary pressure equalizes to the atmosphere, it zeroes it out after a while. The intrapleural pressure does not. And this makes sense because the pleura, they're just hanging out there. There's no structure or any mechanism that connects it to the atmosphere to even have an opportunity to equalize that pressure. The last pressure to talk about here is called transpulmonary pressure. Transpulmonary pressure is the difference between these two, between PIP and PPUL. It's like this. So it's P PUL, P pulmonary minus PIP, intrapleural. The intrapleural pressure must always be less than the intrapulmonary pressure, because if not, that would cause the airways to collapse. So if there's a condition that would cause these two pressures to equalize, this would cause lung collapse. And lung collapse has a special name. I'm going to write it here, lung collapse. Collapse. It's spelled like this. That word is atelectasis, or lung collapse. And atelectasis or lung collapse can happen in a bunch of different ways, but it usually is from like clogged bronchioles, as can occur in pneumonia, severe cases, or when air is in the pleural cavity. And that's usually due to something like a wound. A pneumothorax, which might be one of those words that you've heard about before, pneumothorax, like in Grey's Anatomy or whatever. That's what it's called when there's air in the pleura. So that's no good. We don't want air in the pleura. And in order to treat that pneumothorax, medical professionals, they just insert a little tube that removes that air. Okay, and then this is just a little graphic from our textbook showing you, it's figure 22.14. all of those different pressures that we were talking about. So I'll use my highlighter in pink just to switch out my colors here. So here we have that atmospheric pressure sitting around 760 millimeters of mercury. This is in the trachea though, so we call that 0. Because since our pressure of air in the respiratory tract is the same as the atmospheric pressure, we call that 0 millimeters of mercury. Then we have that intrapulmonary pressure we described. Here's the intrapleural pressure. So the intrapleural pressure is that pressure inside of that pleural cavity. And then the difference between those two pressures is the transpulmonary pressure. So it's the difference from A to B. Pulmonary ventilation is inspiration followed by expiration, and this involves a lot of changes in volumes within the thoracic cavity, because that's where the lungs live, right? When you breathe in and out, you probably notice that your thoracic cavity changes in its size and shape. But what's causing the flow of gases in and out is because the volume changes, which leads to the pressure changing, which leads to gases moving. So it's volume followed by pressure followed by gases moving. And this is described by Boyle's law. So Boyle's law provides a relationship between pressure and the volume of gases. So relationship volume of gases and pressure. What Boyle's law describes is that if we have a container and we have some particles inside of that container, like a gas, here's some gas particles inside of there. We have 1, 2, 3, 4, 5, 6, 7. So if I have a container and I increase the size of that container, so I increase its volume. So if I have more volume, that means my pressure is less. More volume, less pressure. If the flip side occurs, that I were to shrink that container, those particles have less space to move around. So there's more pressure going on in there. So there's more pressure as we decrease the size of that container. So if there's less volume, there's more pressure. So if we increase the size of that container, the pressure in that container decreases. But if we shrink the size of that container, decrease its volume, then we increase the pressure of the things that are in there. It's all about the size of your container, because once the pressure changes, or once the volume changes rather, then the pressure changes, and that's what leads to gases moving. Okay, so keep this in your brain as we're talking about the next stuff. There's a lot going on in this slide. I'm going to zoom in on a couple of things. But what we're looking at is the processes of inspiration and the processes of expiration. So the first thing I'm going to zoom in on is the process of inspiration. There's some steps here. What we're looking at is a picture of the thoracic cage. So we have all of those lungs. We have some muscles here, including the diaphragm. And then we have to remember that the lungs are inside. So first, let's talk about some major muscles. We have two groups of major muscles here. So we have the external intercostals. The external intercostals are these muscles that exist in between the ribs. So intercostals, and then they're on the external side. And then the other one that we have to know about is the diaphragm. The diaphragm is the major breathing muscle. The diaphragm is shaped kind of like a dome when it's relaxed, but when that diaphragm contracts, it pulls and it gets more flat. So when the diaphragm contracts, it gets more flat, and by it getting more flat, it's pulling on all of these lung tissues downwards. All of those tissues within the thoracic cavity. So the thoracic cavity increases this way, vertically. The contraction of the intercostal muscles, what that causes is the rib cage to lift, and it also causes the rib cage to expand outwards. So here we are in cross section. And if you were to take a big breath and kind of feel your lungs, you can or feel your rib cage rather, you feel your rib cage go with that big, big inhale, you feel that rib cage lift up and out. Both of those things, the contraction of the diaphragm and the contraction of the external intercostal muscles, make the thoracic cavity volume bigger. So volume increases in the thoracic cavity. We know that if volume increases, so if we increase our volume, that leads to the pressure decreasing inside of the lung. And that's P, intrapulmonary pressure. Boyle's law tells us that more volume means less pressure. So the intrapulmonary pressure decreases. Intrapulmonary pressure is less than that of the atmosphere. If the intrapulmonary pressure is less than that of the atmosphere, air enters the lungs. Something to know about air is that it'll always go where there's less pressure. Let me draw you a simplified picture here. So both of the actions of contraction of the diaphragm, here's our little alveolus here. So if P pulmonary is low and then the pressure in the atmosphere is higher, what's going to happen to the flow of air is we're going to go where pressure is lower. So then air will be motivated to enter the lungs. And this continues, right? So air will continue to rush into the lungs, rush into the lungs, rush into the lungs until pressure, intrapulmonary pressure, PUL, is the same as. So once those pressures are equal, then the exchange of air kind of halts. It doesn't really matter anymore because they're equalized. Now, what we're talking about is normal, quiet breathing. But if we do a deep breath or a forced inspiration, there are some other muscles that can step in and make our thoracic volume even greater. And then if our thoracic volume is even greater, then that increases this difference, right? So then more and more air will rush in. Some of these muscles that help us with forced inspiration are some neck muscles, the sternocleidomastoid. We have the pectoralis minor, which is on the chest. Straightening the back can also help, like sitting up straighter or standing up straighter can also aid in that forced inspiration. So that's inspiration. Expiration is basically just a reversal of that whole process. So again, we're describing normal, quiet breathing. So it's not like this huge production to expire. This is just a reversal of that process we just talked about. Because it's a reversal, then those muscles relax. They started contracting. In inspiration, in expiration, they're relaxing. So that diaphragm becomes more dome-like. As that diaphragm becomes more dome-like, those organs are getting kind of pushed backwards, shrinking the size of the thoracic cavity. But then also, so we have the diaphragm, but then also the external intercostals, they relax, and that brings the thoracic cavity kind of down, and it also brings the thoracic cavity inwards, as you can see here. This is in cross section. All of those tasks lead to thoracic volume decreasing. We know from Boyle's law that if volume decreases, pressure increases. So volume decreases, pressure increases. That means that in our simplified drawing here, P pulmonary atmospheric pressure. So if the volume or if the pressure increases here, then the atmosphere, and if that rises to make it so that the atmospheric pressure is lower, then air rushes out. So all of these tasks are done shrinking the thoracic cavity so that we raise the pressure inside of the alveolus to push air outwards, because air is always going to go where there's less pressure. Again, this normal, quiet breathing. And these pressure changes are so small. For inspiration and expiration, it's really only about like 2-ish millimeters of mercury. But that allows us for inhalation and exhalation of air that's really beneficial for normal, quiet breathing. If we want to increase that, though, forced expiration is possible, right? And this is done using the abdominal wall, especially the transversus abdominis, and that's the deepest ab muscle, as well as the obliques. Increasing the pressure of the abdomen causes those organs to push the diaphragm up, so we increase more pressure because the abdominal pressure has increased, thus we're pushing on the diaphragm even harder. That also helps the rib cage come back down even more, and that works to further reduce volume, thus we breathe out way more air. The control of expiration especially is really important in athletes and in singers because regulating that air is really important in that performance. So that's inspiration and expiration and how they work. But what factors play a role in how this works? The first one is airway resistance. Airway resistance. And this is basically just like the friction that air encounters as a resistive force to get into the alveoli. So it's friction. And that's resistance. Or R. This is pretty similar, honestly, to what we discussed with blood vessels. Bigger tube means less friction, but a smaller tube means more friction. We learned that in the blood vessels. It's kind of same in the respiratory system. It is a little bit layered though because the size of the thoracic cavity makes a difference. So the size of the thoracic cavity increases, thus volume increases, which increases diameter of those tubes, thus decreasing resistance and friction. You see what I mean? So it takes some steps in order to make those tubes bigger. The process of expiration increases resistance. So inspiration decreases resistance, expiration increases resistance. Because expiration is shrinking those tubes and the volume and everything else. The other thing is that this only really applies airway resistance until you get to the level of the terminal bronchioles. Because once you pass from the terminal bronchioles, you're no longer in the conducting zone, right? The conducting zone versus the respiratory zone. Once you're in the respiratory zone, which is the respiratory bronchioles and onward down into the alveoli, it's not really like airflow issue, it's more of a diffusion thing that happens. So what airway resistance tells us is that if the tube is bigger, there's less resistance, there's more flow of air. This also applies for bronchodilation and bronchoconstriction. If the bronchioles are dilated, as they are in SNS control, sympathetic control, or if they're constricted, that would be parasympathetic control, that also makes it so that there's a difference in resistance. So things that cause bronchoconstriction, for example, like asthma attack, inflammatory chemicals, they act on those smooth muscles of the bronchioles. If those smooth muscles start to contract and constrict very strongly, that can really interfere with ventilation because that resistance is so much higher. Asthma attacks are often treated with things like epinephrine, right? So epi acts on the smooth muscle of the bronchioles, and that reverses this whole process, right? Which is why Epi is a really commonly used thing during an asthma attack, or other things that cause bronchodilation rather. So the next thing to discuss, so that's airway resistance. The next thing is surface tension. And surface tension matters within the alveoli, because within the alveolus, let me draw you one. Within the alveolus, that's one alveolus, there's fluid. It's lined with fluid, and that fluid is mostly water. Alveolar fluid, which is mostly, but not all, water. This matters because water is a molecule that has very high rates of surface tension. So surface tension is the idea that liquid molecules really like each other and they hold on to each other more so than they might try to hold on to a gas. And that produces surface tension in the alveoli and kind of pulls, because all these liquid molecules are pulling themselves together. They're pulling themselves closer and closer, thus shrinking that alveolus as small as it can go. So to combat this high level of surface tension, we have type 2 cells. So type 2 alveolar cells, they release surfactant. And surfactant is a soap-like substance that decreases surface tension. To decrease surface tension, it kind of like gets in the way, kind of like how laundry detergent works. It's like pulling, making it so those liquid molecules don't like each other as much. They don't hold on to each other as strongly. And that makes expanding the alveoli a little bit easier. It doesn't completely eliminate surface tension, it just reduces it. A little bit of surface tension, though, is still good because it helps the lungs come back down to size in expiration, because those liquid molecules are kind of like pulling each other back together. The last thing to discuss on this slide is lung compliance. Lung compliance is the degree to which the lungs are stretchy or distensible, or how much effort you need to stretch the lungs and the thoracic cavity for breathing. And so this involves a couple of factors. First one is how elastic or how distensible the lungs are. Sensibility. And it also depends on surface tension and the alveoli. So distensibility means how stretchy, and then surface tension is referring to like all of this stuff that we were just talking about. In normal, healthy lungs, the lungs are very distensible, and that surface tension is low enough. And so the lungs are very, we would say, compliant. But there are different issues that can interfere with lung compliance, right? Like if there's scar tissue, that would make the lungs a little bit less stretchy, for example. If there's fluid or mucus in the lungs due to things like pulmonary edema, bronchitis, pneumonia, but also if that surfactant isn't produced as much, because that starts to affect surface tension. So premature babies commonly don't have enough surfactant being produced by the cells in their alveoli. And so this can commonly be an issue because our lungs aren't as compliant. And so other medical interventions are needed. But there's other things that can interfere with lung expansion, like issues with the breathing muscles, abnormalities of the thoracic cage, that kind of thing. The lungs change their size when we inspire and expire air. And that means that the volume of air that's in there at any one time can change. So respiratory volumes, they describe how much air is moving in and out of the lungs with each breath. So I'll write that down for us. How much air is moving in or out with each breath. With each breath. And there's a couple of different examples of respiratory volume that describe different things. So, for example, tidal volume. Tidal volume is the volume of air during normal, quiet breathing. So that's about 500-ish mils. We also have inspiratory reserve volume, or IRV. IRV is the amount of air that can be inspired during forced inspiration. IRV is about, give or take, 2100 to 3200 ml, which is beyond tidal volume. The flip side would be the expiratory one, expiratory reserve volume, and that's called ERV. Expiratory reserve volume is the volume of air forced out during forced expiration, and that's 1000-ish to 1200-ish mils, again, beyond the tidal volume. The last one I think is interesting. It's called residual volume, or RV. Residual volume is because the lungs are never empty. There's always about 1200 ml of air in the lungs at any one time. This is important because having some air left over in there makes sure that the alveoli are open, because closed alveoli means lung collapse. Closely related to respiratory volumes is respiratory capacity. Respiratory capacity describes the relationships between the respiratory volumes. Relationships between respiratory volumes. So if you were to add up all the lung volumes together, for example, like add up all this stuff, you'd get about 6,000 mils, or 6 liters. And that would be for males. And then you'd get about 4,200-ish mils, and that would be for females. There are some differences between male and females, and this is describing total lung capacity. So how much all of your lung can hold if you combine all of these volumes here: tidal volume, IRV, ERV, and that residual. Another related term is vital capacity. Vital capacity is the total amount of air that can be expelled from the lungs after the biggest possible inhale you can do. So it's like the most air that you can breathe out at any one time. So again, it's describing different relationships between respiratory volumes, these capacities. Assessing ventilation is important because we understand how the respiratory system is working, right? And pulmonary testing often involves the use of the spirometer. And that's a little machine that you blow into. It measures the amount of air that you breathe out. And that's used primarily to evaluate like how your respiratory system is functioning, and also for monitoring the progression of any respiratory diseases that might be occurring. Another way to assess ventilation is through alveolar ventilation. There's 2 examples here. The first is minute ventilation. Minute ventilation is the total amount of air going in and out in 1 minute. So total amount of air going in or out in 1 minute. On average, normal quiet breathing, that's about 12 breaths per minute. So that would be about 6 liters per minute-ish. During exercise, though, this minute ventilation increases, and it can be as high as like 200 liters per minute because that rate is really increased, right? Um, AVR or alveolar ventilation rate, that's this one here at the bottom. It's another more rigorous way to measure ventilation because it also takes into account this thing called dead space. Dead space. Dead space is the air that kind of just hangs out in that respiratory tract. It doesn't really do much breathing wise. It just makes it so that the depth, so measuring AVR makes it so that the depth of breathing matters more than the rate. Breathing deeper means that there's more time for gas exchange to happen. That's a little bit slower. And then the rate of breathing, like short and shallow breathing, it doesn't allow a ton of ability for efficient gas exchange to occur because we're taking into account all of that dead space that's involved. So both of those things are used commonly when assessing ventilation. It just depends on what you're looking for. That's the end of this video. I hope you enjoyed it. I look forward to talking about this stuff with you in the lab, and I hope you have a good one.